Welcome to Health or Consequences, the podcast of Commonwealth Magazine's devoted to healthcare and public health policy. I'm Paul Haddis, recently retired from Tufts University, here with my colleague, John McDonough from the T.H. Chan School of Public Health. And we're very excited today to have a guest we've been waiting to have on until finally, as you'll hear in a moment, the merger that he's now seeing of two companies as the CEO or overseeing, Tom Croswell, CEO of the combined entity of the Tufts Health Plan and Harvard Pilgrim Healthcare, who have come together. And we're delighted that's news that finalized this past month. And then even a couple of weeks after that, we learned that Tom announced to the world that he was going to be stepping back from a 50-year career from Tufts and the health insurance field later this summer. So, Tom, we're delighted to have you, and we look forward to this conversation very much.
Thank you. It's really great to be here. Hard to believe it's been 50 years, but time does fly.
And I think John's going to get us started today.
I'll get started. Thanks for joining us, Tom. It's a pleasure and honor to have you with us. So we read and we learn that your new company, the merged company, expects to save at least $100 million from what are referred to as administrative synergies from the merger. When and how will this be evident, and how will it directly impact in a favorable way consumers of the new company?
Sure. These synergies are going to be realized through the integration work, which has really just begun. We did a lot of planning on how to integrate the two companies, but it wasn't until January 1st when we closed we could actually begin work. It will take about 5 years to fully realize those synergy savings. It takes a long time to fully achieve them because a significant portion comes from eliminating duplicate infrastructure in the two companies and removing that duplication without adversely impacting our customers takes very careful planning and execution. I mean, the example of that duplicate infrastructure are different computer systems that are used to pay claims. We will over time be moving to consolidate onto one platform. And again, that takes time and careful planning. The bulk of the savings that we will achieve through this integration, these synergy savings, will be passed on to customers through premium savings. As you know, our premium rates are filed and approved by the Department of Insurance. So these savings will be reflected in those rate filings. The Health Policy Commission has also indicated that it intends to be monitoring our progress. So we'll have some transparency in that regard as well. Beyond premium savings, we also will make investments consistent with our mission as a not-for-profit health plan. We didn't combine these two companies to produce a return for shareholders. We don't have shareholders. We did it to further the achievement of our mission, which simply stated is to improve the health and wellness of the diverse communities we serve. So we're going to be focused on things like access for all. We'll continue to provide coverage that works regardless of a person's age, health, race, identity, or income. We're going to be focused on addressing racial justice and promoting health equity. An initial example in that area is the $1 million grants that we recently announced to community organizations to support education, outreach, and support on the vaccine to Black and Brown communities. Another area I would highlight is behavioral health. We will be prioritizing integration of medical and behavioral health management as a major priority for the new organization. And a final area that I would mention beyond premium savings, investments we'll be making to streamline the consumer experience. Both companies have paid a lot of attention, invested in the past around digital tools to help our members better navigate the fragmented healthcare system. We expect to continue those kinds of investments. And here's an example of where synergy savings can come in the form of the same dollar investment, but a broader application. We can eliminate really duplicate investments and use that money to invest in a broader range of tools. So I think there's a lot of benefits, but I'd kind of start with premium savings.
To Tom, will consumers and employers see products still named under their historical company names, Tufts and Harvard Pilgrim, and will there be a single name for the whole company?
For this foreseeable future, we will continue to operate in the marketplace with our existing brands. That's necessary just from a regulatory standpoint. Again, we need to file our products with regulatory bodies, and we do it with our existing brand names. So it's going to take a while for that process to play out. So for at least the next couple of years, we will operate with our existing brands. We will be selecting a new name for the parent company, and over time we'll be developing a plan to move that forward into the marketplace. But for the foreseeable future, expect to see our existing names.
Tom, I move to a question I think a lot of our podcast, a very sophisticated audience often is probably wondering about, and it has to do with the general market of healthcare services and insurance we have in Massachusetts. As you know, for a while now, we've had a very consolidated provider market, and now you're coming together. Your two plans increases the consolidation on the insurance side, and most economists looking especially at the provider side, but even the insurance side, say that we often don't see lower costs when those kinds of things happen. But I want you to take a look at our particular market here in Massachusetts, which now has the kind of consolidation I noted. And what should consumers really expect in terms of premiums and rate increases?
Well, the impact of consolidation of insurance companies is really very different than provider organization, for example. We really believe that our combination will enhance market competition and result in premiums lower than they would have been absent this combination. As I said a few minutes ago, we expect this combination to generate millions in savings, the bulk of which will be passed on directly to consumers through lower premium increases. These savings were validated by economists as we worked through the regulatory review process. In addition, with our increased scale, we will work with providers on expanding alternative payment arrangements, which we believe will make coverage more affordable and improve the quality of care. That a significant concern for providers entering into risk arrangements, these alternative forms of payment, can be the size of the covered population. Essentially doubling the size of our company should eliminate some of those concerns and make it easier to expand the use of those alternative payment arrangements. Overall, we operate in a very competitive market, and it will be no less so after our combination. We have very strong local competitors, and we have national health plans, insurance companies that are very active in our market. A key element of competition is around price, premium levels. And for us to be successful going forward, we need to keep premiums as low as possible. So again, we don't really see this materially changing the competitive landscape, and the pressure is on us as much as ever to keep premiums as low as we can.
You mentioned the national insurers, and one of their divisions, Optum, actually now is going to be purchasing our largest independent nonprofit physician group, Atrius, or at least there's a memorandum of understanding to make that happen. And Optum's division of United Health. How do you see this particular purchase impacting contracting and pricing in Massachusetts for physician services or hospital services? And is this a good thing or not?
Well, Atrius and Reliant Medical Group, which is now, as you know, part of the Optum family of companies, let's call it. They've been important partners to both of our heritage organizations for many years. In fact, Harvard Vanguard, which was kind of a forerunner to Atrius, was actually part of the Harvard Pilgrim organization for many, many years. And we certainly understand the financial pressure that Atrius has felt, which have been even greater due to the pandemic. Um, at this point, I'd have to say I think it's difficult to tell whether this acquisition, if it goes forward, will be a good thing. I think we need to understand it better. And I think it should be evaluated based upon whether it improves affordability and quality. Based on my conversations with Atria's leadership, that seems to be the goal here. So I certainly look forward to working with both organizations, both parts of Optum, going forward to enhance the care our members receive. You referenced studies and evidence that consolidation often increases prices and costs. Certainly, if that were to happen here, it would not be a good thing. So I guess at this point, I'd have to say that the jury is out.
So if I could ask a follow-up to that just briefly. So Optum is part of United Health, which is for profit. Massachusetts, as you folks, your two organizations exemplify, characterizes the nonprofit nature of the Massachusetts health system. Is this a significant, substantial, meaningful dent in the nonprofit profile of the state? And should there be some concern that we will see a cascade of other takeovers in Massachusetts by the national for-profit systems?
I think that's hard to predict, John. I mean, I think this is certainly a material development. As you point out, for many, many years, the healthcare system, both on the provider side as well as on the health plan side, has been really characterized by a not-for-profit presence. And, from our standpoint, the national not-for-profit organizations certainly are formidable competitors. They have the size and scale that makes them really very strong competitors. So, I think in increasing presence, it gets back to what I said earlier about the competitive environment here. I think, our combination, I don't think really changes that materially, but certainly the increasing presence of national companies, not typically for profit, I think certainly is a force in the market.
So we saw the merger of your two organizations, which essentially Tufts and Harvard Pilgrim, number 2 and number 3, coming together to be a more comparable match to the number 1 insurer, Blue Cross of Massachusetts. A couple of years ago, we saw Beth Israel Deaconess and Leahy Health come together to try to form a more equal counterweight to the marketplace power of Partners Healthcare, now Mass General Brigham. Have we seen benefits from the Beth Israel Leahy merger? Has that resulted in savings that you're able to see? Because you would see it probably better than anybody as you make negotiations and contract with these folks. What have been the benefits, if there are any, from what you've seen from that merger?
Well, I think I'd start by saying that Beth Israel Leahy Health is a very important partner to our combined organization, and they serve our markets and they serve our members in the commercial Medicare and Medicaid markets really across the board. And we have continued to work with BI Leahy Health on innovative contracting structures that best support efficient quality healthcare. The question as to whether the combination has lowered costs versus what they would have been absent the combination, frankly, is a tough question to answer definitively, in part because the combination is still recent. And again, we're trying to measure against something that would have been in the absence. You're well aware that certain commitments were made at the time of the combination to regulators, and results versus those commitments will be monitored. I've said before, and I still believe that I think running a hospital is one of the toughest jobs in healthcare today. And when you think about, the complexity, the size of the BI Leahy organization, academic medical institutions, community hospitals, provider groups. It's really an extraordinarily complex organization. Given that, I don't think that BI Leahy has yet kind of hit its stride. My guess is it's going to take longer to really fully achieve the goals that Kevin Tabb and his leadership team have laid out. So again, a long-winded way of saying I don't think the results are in yet on that. I think from a strategy standpoint, they seem to be focused on the right things, cost and quality. And we're certainly working together with them to achieve lower costs and better quality as we go forward.
From your point of view, is bigger always better?
No, it's certainly not. I think the proof is in the pudding. There are, even when it comes to scale advantages, you need to be able to execute effectively to achieve those scale advantages. It can also translate to, if you're not careful, to more bureaucracy and just a less nimble organization. So no, I don't think bigger always means better.
Okay. And just shifting gear just a little bit. So the new Biden administration is proposing some significant changes for the subsidized coverage under the Affordable Care Act to deepen the subsidies, to expand them to folks with incomes over 4 times the federal poverty level. They're also interested in a public option, although it looks like that may be difficult to get through. How do you judge, evaluate, and welcome or not welcome the changes that we're seeing coming out of the Biden administration on access and subsidies at this point?
We support improved access and affordability for our customers. So to that end, we support greater subsidies that help people obtain coverage. In terms of the public option, I think details really do matter. If a public option were to compete on a level playing field and resulted in lower costs for the Commonwealth's residents, we certainly would not oppose introduction of a public option. If, however, it included features like mandated provider rates that resulted in a cost shift to other segments of the market, like employers, then we'd be concerned. Unfortunately, that's how some of these proposals have been constructed, which is why insurers and providers have raised concerns. So again, I think it depends on how things play out. But in terms of subsidies, we do think it's important that people have the financial ability to access insurance coverage.
And do you see that helping people in Massachusetts? Because Massachusetts already has a lower subsidy structure. So is there a benefit here for Massachusetts consumers?
Well, we still have a segment of the population that doesn't have access to coverage. So I think, perhaps less so than in some other states, but sure, I think there is a potential benefit.
Tom, I'm going to bring you back to Massachusetts and ask you, as we're now about slightly over 8 years into the existence of the Massachusetts Health Policy Commission and its sort of oversight of its signature healthcare cost growth benchmark and other kinds of things. When you step back and look at what they've been doing over that time, where have they succeeded and where have they fallen short in ways that are important to the Commonwealth?
I think the Health Policy Commission really has played an important role in using the data and analysis provided by CHIA to measure and report the state's progress on meeting cost containment goals. I'm really not sure we have achieved the progress that we have without the Health Policy Commission. As you know, Paul, as a former commissioner, the HPC was given the authority to convene stakeholders to testify on their progress in achieving the cost goals, and to put those stakeholders on improvement plans when they fall short. I think this has resulted in some very important and effective public dialogue around recommendations for continued improvement in cost and quality, which I do think has had an impact. I think where the Health Policy Commission has been challenged is with respect to the limits on its authority and with the retrospective nature of its reporting. In terms of the limits on its authority, I think we've seen that most acutely in its inability to address effectively the cost of prescription drugs or to hold drug manufacturers accountable. I know it's been frustrating to come and testify at the HPC's annual hearing, along with providers about what we're doing to control costs, and everyone is there, held to a certain level of accountability with one glaring omission, and that's the drug manufacturers. So I think that's been a challenge for the HPC. In terms of the look back period on reporting, it can be several years behind, and cost pressures and trends and appropriate interventions can change more rapidly. If we're talking about a corrective action plan to deal with the events of 2 or 3 years ago, that can make it less impactful, let's say.
Tom, I'm a little bit worried, as a brief follow-up here, that with COVID, and really when we had David Seltz on recently, it more or less is going to, the effects in terms of affecting healthcare spending is going to make examination of performance related to the benchmark very difficult for a couple of years. And your colleague, Andrew Dreyfus, at the cost growth hearings did say something about getting very high rate increase requests from a number of different providers in this environment. I wonder if you have any reflections there. The HPC really isn't empowered to directly deal with those things. Well, do you have any thoughts about that?
Well, I think, we've seen some of that same pressure from providers who, have been felt a financial pinch clearly as a result of COVID, the need to shut down elective surgery and that sort of thing. So we have seen that translate into some requests for higher unit cost increases than probably would have been the case otherwise. Part of our job is to negotiate as effectively as we can to try to hold those kind of increases to a minimum. I think we're doing a reasonably good job of that, but there's no question that there definitely is pressure. COVID still, the impact on premium rates and health plan performance is still a little bit of a black box here, because it's been hard to predict what will happen with the vaccine rollout, mutation of the virus, what kind of suppression of healthcare services it provides, and what kind of what's the impact of deferred care. So I think I wish I had a perfect crystal ball on this, but I think it's we're going to have to work through this for a number more months to really figure out what the real impact is.
Let me give you one more aspect of COVID, and you and I briefly talked about this in the past. We know that primary care doctors in some ways suffered because of fee-for-service billings during at least the spring surge of COVID, to have adequate revenue flow. And a lot of them are saying we really need to move more to a capitated system for primary care, which is not only good for the revenue flow, but really good, they think, from the best way to care for patients in terms of the right incentives. What are your thoughts about that?
Well, we certainly understand that the pandemic and this period of lower utilization as a result of the suspension of elective care created some material cash flow issues, I think particularly for smaller independent primary care practices. And we also certainly understand that some groups see capitation as a way to address those cash flow concerns. And we certainly support capitation arrangements, alternative financing arrangements that are structured appropriately to reward value. We have many of those kinds of arrangements in place today. We do think that primary care physicians need to be able to manage the risk of these arrangements, which requires infrastructure and capabilities for them to be managed successfully. Those capabilities vary a lot from one provider practice to another. So responding to this concern is not a one-size-fits-all situation. Contracting approaches we think need to develop that work for each provider organization. But we stand ready to work with independent PCPs as they seek to move to alternative payment arrangements. Even more so given our larger scale as a result of our combination. Going back to that point I made earlier about a larger population more easily facilitating these kinds of structures.
So last year, Tom, the Governor Baker signed a new law passed by the legislature that included a lot of different pieces, but one of them that got the most notice was around telehealth and continuing to make sure that there was parity reimbursement for that. Did they get it right from your perspective? And how do you feel about the other steps going on in terms of behavioral health and telehealth parity for that?
I think the legislature and the governor did largely get it right. We're very supportive of telehealth, particularly for behavioral health, where access to care is often a problem, at least in some regions of the state and for certain populations. We know that delivery of care through telehealth is critical during the pandemic. In fact, it's really remarkable what has occurred. Before the pandemic, for us, telehealth represented less than 2% of the claims that we received for outpatient visits. In April, 60% of all physical health visits were through telehealth. Today, it's about 20%, so down materially, but still way above what it was back in February. For behavioral health, it's about 80% of visits today that are occurring through telehealth. And that's remained pretty much constant over the last 11 months. So, huge change in a very short period of time. So yes, we do believe that the legislature got it right. Supporting telehealth clearly was critical to getting us through the pandemic and opening up access to care on a safe and convenient basis. As far as payment parity is concerned, I do think at some point we may want to revisit these policies to ensure that consumers are getting the best care and value from telehealth. We do think that this delivery method should be less costly than in-person office visits. So again, it comes back to value for our consumers. But I think it was the right thing to do at the right point in time.
Tom, you mentioned the HPC's limited power to really affect rising costs of prescription drugs. But is there anything really at the state level the legislature ought to do, whether it's affecting the HPC or something else, to try to deal with that issue? And do you expect anything for the federal government to do on prescription drugs in this new Biden administration and Congress?
We do think that this requires federal action, and we certainly hope to see the new Congress and the Biden administration take some action to curb the cost of prescription drugs. I'm really not the person to handicap what the odds of that happening will be. I think but certainly there does seem to be some focus on it, and we're hopeful that some action will be taken. In terms of state action, as a very first step, we believe that increased transparency is important. We've supported this for many years. Drug manufacturers, and I would put PBMs in this category, pharmacy benefit managers in the same category, should be held accountable for the cost, just as providers and insurers are held accountable by state regulators and bodies such as the Health Policy Commission. I welcome the day when drug manufacturers and PBMs are at the table at the Health Policy Commission hearings. Insurer premium rates are reviewed by regulators. We think drug manufacturers should be subject to a similar review to make sure that consumers are getting fair value and the drugs remain affordable. It's wonderful to have the introduction of effective miracle drugs, certainly to celebrate. The challenge obviously becomes if they're so expensive that they can't be accessed, then that's a big issue. So hopeful there'll be some action at the federal level, but I think transparency here in the state would be the key thing I'd highlight.
And so, Tom, I have the honor of asking you the final question. Congratulations on your decades of leadership in the Massachusetts health system in so many ways, and keeping Tufts Health Plan to be one of our premier and most important insurers. Do you have any advice for your successor? And do you have any final words of wisdom for policymakers on Beacon Hill and for your customers and the citizens of Massachusetts about what's important to keep our eyes on looking into the future?
I guess I'd offer, a few thoughts. First, I would make sure that we intensify and continue the focus on social determinants of health and health equity, not just during the pandemic, but beyond. I don't need to recite the depressing statistics about life expectancy and disease prevalence in Black and Brown communities. The drivers are very complex. We need to better understand and address them. Let's get to where everyone has access to the high quality care available here in the Commonwealth, and people are not systemically disadvantaged in getting that kind of health equity. A second bit of advice I'd give is to take a collaborative approach to problem solving. The state was able to achieve near universal insurance coverage through very strong collaboration. A shared responsibility model, I think was the term that was used, that involved all the major players in healthcare and insurance. I think we all recognize what the challenges are: cost, access, and quality. But when we try to find common ground rather than take sides, I think we tend to be more successful. And I guess the third bit of advice I'd give for leaders is to repeat the advice I got from my father many years ago. And that is, don't take yourself too seriously. No one else does. I think a little humility goes a long way in garnering support for what you want to achieve. So I guess if I had some parting advice, if you will, those would be what I'd highlight.
Tom Croswell, CEO of the new combined insurance entity of Tufts Health Plan and Harvard Pilgrim. Thank you really for both the interesting and wide-ranging conversation today. We wish you the very best, and we wish our listeners to come back and join us next month for the next episode of Health or Consequences.